Dr. Anu Korula, who is the Professor of Hematology from CMC Vellore. Madam is a very well-known published author and has a keen interest in areas of stem cell transplant in primary immunodeficiency disorders as well as in lymphomas. She's here today to talk to us about the enigma of MGRS. Ma'am, I hand over the stage to you.
Thank you very much, and thank you to the organizers for inviting me to give a talk here today. So the topic which was given to me is actually about monoclonal gammopathy of renal significance. So before I start the body of the talk, just to say the intent of this talk is not to give you a detailed description of each of the entities which are involved in MGRS or the treatment specifically to all these entities. So the objective of the talk is actually to tell what are the diagnostic and management challenges that we face as a multidisciplinary team when dealing with this entity, and where the pitfalls and where we are missing these cases are. So I think I'd started by actually saying that I started thinking about MGRS a few years ago when I met one of the nephrology consultants. We were having lunch in the mess, and I asked, why are these patients coming to us? They don't have an M band. They've got some proteinuria. I just couldn't, I knew that there were scattered cases coming in. And every time I saw him at lunch, I would ask the same thing. And then, so finally, we decided to have a meeting between nephro and hemat and figure out what exactly to do with MGRS. So we had presented the hematology perspective in MGRS. Basically, we were focusing on a very suboptimal understanding of this entity because we knew that it is an MGUS and there's some renal damage. And we also knew that some recommendations are that you should give chemotherapy. But we really did not have any clarity if there's renal dysfunction, why is it not CRAB? As hematologists, we didn't have any idea about the histopath spectrum of MGRS. So when the biopsy comes, it means something to the nephrologist and the pathologist, but it doesn't really have much meaning to the hematologist. And the last thing was, what were the treatment approaches within this broad MGRS? So we went about having this little meeting. We didn't come to a conclusion on how we would treat, but I think just the recognition from both sides that there was a problem led to us identifying and treating more cases. So why is it so under-recognized by hematology? MGRS is a relatively recent entity. It was first described in 2012, and this was by the International Kidney and Monoclonal Gammopathy Research Group. And I realized this when I read up for this talk, because I know that it is, in fact, it has come into the hematology lexicon only in 2022, and that is like hematologists go by the WHO classification for all hematological disorders, malignant ones, and it's called a blue book. Pathologists would know that they have a blue book for every disease. So MGRS has never been mentioned in this, and it's not one of the plasma cell entities. But in 2022, this has come into the WHO Hem5 classification, and it's an official entity. So it's described as a clonal B cell or plasma cell disorder. So it is clonal, but it doesn't meet the criteria or doesn't cause the sort of damage that a full tumor burden clone would do. And it does produce a nephrotoxic immunoglobulin that directly or indirectly results in damage to the kidney. So these are the only things really described about it which are very, very clear. So this could be a B cell or a plasma cell, and it can be any of the immunoglobulins. So there are no, to date, published clinical trials in MGRS. There's no consensus on management, and the data that's there also, people have given 20-year data, but the entity only came up a few years ago. So it's not really also clear what the exact treatment protocols we should follow. So how do hematologists view plasma cell entities? This is important to know because lot of hematologists, we go by these classifications. The first one is the WHO 2016, and you can see here that you have the MGUS here, the monoclonal gammopathy of undetermined significance, but there is no MGRS. In 2022, this monoclonal gammopathy of renal significance is even introduced into our classification. So people it comes on the radar. But actually there's this other classification called the ICC classification. It's an internal consensus classification. There's some sort of a controversy between these two groups, and a large proportion of the world still follows the ICC classification, and you can see that there's no MGRS there. So the problem is that it's not really on our radar. Though we know it exists, it's not very clear. So how do we define MGUS and MGCS? Because as hematologists, we get referrals not only from nephro, but also from neurology. And this is a monoclonal gammopathy of clinical significance. So it mainly affects the kidneys, and also some cases affect the nerves and sometimes the skin. So this is where the symptoms or signs or the features are unexplained by the clone size that we are seeing. This is a non-malignant but clonal proliferation. And if you look at a very simplified definition of the clone size, so if it's more than 10% and there is end organ damage, it's myeloma. If it's more than 10% and there is no end organ damage, it's smoldering myeloma. There are other criteria as well. Less than 10%, no damage, MGUS. Less than 10% with end organ damage, it becomes one of the gammopathies of clinical significance, of which MGRS is one. So what is the role of the clinician versus pathologist? And this is again a problem I think in hematology, because this is just a case report, and somebody has nicely put the slide up showing that. I'm not sure if you can see, but on the top it gives all the clinical features, that is peripheral neuropathy, renal involvement, skin involvement, and etc. And on the y-axis on the left side, it gives the different syndromes which are included, that is amyloidosis, Poem syndrome, fibrillary GN, immunotactoid GN, etc. And you can see that here, where you come down to where the kidney is most affected, it's actually, the clinician doesn't have much of a role in this diagnosis. It is the pathologist's role, which actually will give you the diagnosis of any one of these entities. And that can vary. There are certain syndromes which are very clearly clinically, the whole syndrome is clinical, but in these, it is a histopath diagnosis. So MGRS is classified according to the site of the immune deposition, either glomerular, interstitial, or in the vasculature. And it can be divided again into organized, non-organized, or sometimes there's no clear immunoglobulin there. But this is a sequence of the immunoglobulin which results in the last group. So again, like I've highlighted the ones which are most common, that is AL, amyloid, the light chain proximal tubulopathy, and the PGNMID, but I'm not going into the details of this. This is what the histopathology looks like, and these are the most common ones. But again, as a hematologist, when these diagnoses come, it really doesn't, it's like one little bit of white noise which I see. So going back to the meeting again, so before that meeting, I asked one of the nephro consultants to just pick out the last 5 cases that they had referred to us, or the last 5 cases that fell into the MGRS spectrum. And we found that the 4 cases were not referred to hemat, and the 5th case seen in hemat and said as it's an MGUS and sent off. So there was a problem. But what happened after that was, nice thing to see was, 2022 after the meeting, 23 and definitely in 24, we have had, and this is just the number of cases we are diagnosing in hematology as MGRS. So the recognition is there. That is the first step. So at least like about 50, I would say double the number of cases of MGUS, at least half of them, we are recognizing an entity as MGRS. So it's either that we had a meeting or that it entered the HEME 2022 classification. It's one of the two. Both happened in 2022. So this is the recommended evaluation for MGRS. This is from the same group, the International Kidney and Monoclonal Gammopathy Research Group. So for a patient with a possible, they have looked at it in a different way. They have looked at it when the patient comes to a nephrologist. They're not looking at it when the patient comes to a hematologist. So this is a patient who comes to nephrology with a possible MGRS. And they've recommended when the biopsy is advised, when to consider a biopsy, and when to defer a biopsy. And at the end of this, when the patient has a renal biopsy that is showing the spectrum of MGRS, is the referral to hematology. So the diagnosis, what they say is the diagnosis of MGRS should generally be established before obtaining a hemat consultation. Now, one of the problems of this statement, the way I see recognition, is that if you have a known MGUS and a normal creatinine, patient would have gone to hematology. They see an MGUS and say there's no renal damage and send off the patient. That is also missing a group of patients. So first step is definitely an experienced nephropathologist to make this diagnosis. Second being the nephrologist to, I think, recognition of the entities that comprise this spectrum and refer to hemat for completion of evaluation. So the hematologist at this point has to recognize that this entity, why they have been referred this patient, and needs to complete the evaluation. But the second part is actually, hematologists should be recognizing that MGUS, with what we don't even measure for other forms of renal dysfunction except for the creat, that these may be MGRS, and refer to nephro to rule out an MGRS. So that back referral should happen, and a revisitation of indications for renal biopsy in these patients. So the question of MGUS and renal, say CKD, or if there's any sort of renal dysfunction, kidney disease and MGUS, both are common in older patients. So which patients should you biopsy, and what is the chance that you'll find an MGRS in one of these? So this paper partially answers this question, the rate and predictors of finding MGRS in patients who have monoclonal gammopathy. This is a retrospective review of 6,000 patients, of whom 2.5% had a biopsy. They didn't go into the reasons why, what were the indications for biopsy, but of those who had a biopsy, 40% had MGRS. They also, in the same paper, looked at patients with CKD and MGUS, and of the patients who didn't have a biopsy, they went into the details why biopsy was not done. So again, I don't know, this is very small, it's not clear, but let me just read out that one of the findings was that in the biopsied patients, they found that 40% had MGRS. They found that the most common was AL amyloid, and the second, that was the most common diagnosis of MGRS. What are the predictors of MGRS when you do a biopsy in MGUS? The first is if the patient has proteinuria of more than 1.5 grams. The second is hematuria, and the third is there's an abnormal FLC. So again, if you think of these patients who are sitting in hemat with MGUS, we're not sending them to nephro. So that is the first point that we should do. The second thing they looked at was a patient who has CKD and why they didn't have a biopsy when they had an MGUS also. These were the reasons. The first, the most common, 40% of them, was that the nephrologist or the hematologist did not address the CKD or the MGUS and feel that they needed a biopsy. The second was there was a low suspicion for MGRS, and then it goes on to other things. So the kind of conclusion of this paper, I think this is in a nephrology journal, is that proteinuria, hematuria, and an abnormal FLC do increase the likelihood of finding an MGRS in a patient with MGUS, and biopsy should be considered in these patients. So the possible points of error in recognition and management of MGRS, I don't think, I'm not the expert to say about the histopathology report and how often that is picked up, but revisitation of referrals for just a plain setting of MGUS, who are the patients who actually need a biopsy. The second, and definitely in hematology, is to recognize the reason for referral. Now these reports are not, most people are not familiar with these reports unless there's a very clear clone. So if there's an abnormal FLC, there is an M-band, it will be on the radar, but often this is not the case. So it would definitely help if the referring nephrologist mentions that this is why the patient is referred, to exclude these things. The third is that the detailed evaluation for the clonal lesion, and also it's important to remember that not all patients will have a detectable clone. So that does not rule out the MGRS. So they would have electrophoresis, immunofixation, kappa lambda light chain ratios, bone marrow. So if it's an IgG, it's most likely going to be a plasma cell clone, and if it's an IgM, the likelihood of a Waldenström's or a CLL. So the last step, I think, is very important, is a discussion between the nephrologist, hematologist, to kind of come to a conclusion, treatment plan, diagnosis, and discussion with the patient over overall prognosis and the overall treatment plan. So what are the long-term outcomes in patient who has got a small clone, some renal dysfunction, with and without treatment? We do know that patients don't respond well to immunosuppressive therapies, that's steroids, cyclosporin, MMF, which are other ones which are used for other immune nephropathies. Very importantly, there's a very high rate of recurrence after renal transplant if this monoclonal gammopathy has not been addressed. And there is an increased risk of progression to hematological malignancy when compared to MGUS, but this data is based on very small patient numbers. So if we want to look at the the data on treatment of patients who have a documented MGRS. So I have shown some of this data to actually just show the lacunae in the data more than the fact that there is a very clear treatment plan. Okay, so this is a multi-center retrospective study, 2006 to 2021. So it's a long time period with patients who had a biopsy-proven MGRS, of whom the vast majority are AL amyloidosis. So if we look at the numbers here, the treatment which we give for plasma cell clones is bortezomib based. It's based on immunomodulatory drugs, immunosuppressive therapy, and autologous stem cell transplant. But if we look at the patient numbers who have been treated in this study, they're really very small. And there's no clear, I think, information we can glean from 6 patients and 5 patients who've been given autologous transplant. This is a slightly larger cohort. It deals with MGRS, real-world data on outcomes and prognostic factors. So if we look at the 2 columns, the first one is MGRS with amyloidosis, and the other one is every other MGRS. So the vast majority of patients actually have amyloidosis, and about 1/3 of them may have another diagnosis. So these are the other types of MGRS which have been described: MIDD, PGNMID, light chain proximal tubulopathy, etc., but in increasingly small numbers. I think the lab parameters, there is nothing really which strikingly stands out here, except that in amyloidosis, it tends to be a lambda light chain, and in MGRS, it tends to be a kappa. You can see that it's shown in the abnormal kappa lambda ratio, that is the FLC ratio, which is positive in MGRS, which means it's a kappa light chain. The other feature which is little striking between these 2 groups is that usually the creat is slightly elevated more in the MGRS which is not amyloid compared to amyloidosis. So here, this is a hematology journal, and they have described 200, almost 300 patients with these entities, but the only line they have talked about treatment is this. The most common first-line treatment was proteasome-based, followed by conventional therapy. To me, that's a very, very vague statement to make. So they have said first line, second line, third line, but there are no further details. Now, we know how we treat patients with myeloma, and we assume that it's the same treatment that they are giving, but one would expect, I mean, slightly more details when you're talking about the largest series there is about these patients. So what is the overall survival of patients who have MGRS? So in this cohort, the median overall survival was 120, it was about 10 years. And the outcomes overall were better if you didn't have amyloidosis, if you had one of the other MGRS. Deaths were higher in amyloid, and this was partly related to extrarenal cardiac death. So after now I did mention that they haven't said how the patients were treated, but if we go to the treatment outcomes are measured in 2 ways. One is the plasma cell clone, or sorry, either the plasma cell or the lymphocyte clone, and the second is the renal response. So VGPR refers to a very good partial response, that is in relation to the paraproteinemia. And patients who have had a very good partial response have an excellent outcome in both MGRS A and non-A, compared to those who have a partial response or a progressive disease. Again, patients who have a good renal response have a better response compared to those who do not have a renal response. Renal response is defined in this study as a reduction of more than 30% of proteinuria in the absence of worsening of other renal parameters. So a VGPR increases the likelihood for a renal response. That also is known. So basically, whatever treatment you give, if you go into a VGPR, outcomes are superior to if you don't. The treatment goals, what are the treatment goals in MGR? This is not a life-threatening condition. What happens to patients is they have either a slowly progressive or a rapidly progressive decline in renal function, and that is what is the prevention of that is the goal of therapy. So one, it's preservation of renal function, and two, it's preventing relapse or recurrence of this disease if the patient is planned for a transplant. So for example, if a patient has, we have to tailor it to what the patient's renal, like I would suppose the treatment plan from nephrology is. In that, suppose a patient has advanced CKD, preservation of renal function is unlikely. But if they're going for a transplant, we would treat to avoid recurrence post-transplant. If they're not candidates for transplant, the recommendation is that you treat only if there's extra renal involvement as well. So the treatment itself is clone directed, either to the plasma cell or the lymphoid clone, and this is found to be superior to immunosuppressive therapy. And we do have to balance the risk of myelotoxicity, myelodysplasia, and these are often less with the newer agents like the immunomodulatory drugs, that is lenalidomide, thalidomide, and the proteasome inhibitors like bortezomib. The role of autologous transplant is not very clear. It is advised, but I think the data is premature to say what are the outcomes because the numbers are very small in the treatments given. So this is again, it's one of the review articles on how to treat MGRS, but again, the strength of evidence is not very large. So we would say that any patient who has got type 2 cryoglobulinemia or clear lymphocyte, a lymphoma clone needs to be treated with rituximab. But everybody else treated like a multiple myeloma. That is either with melphalan, dexamethasone, cyclophosphamide, bortezomib, thalidomide, depending on the patient's other comorbidities and their age. So these are the general recommendations on how to treat. So there is a large amount of lacunae in literature. I think there's a lack of, this lacunae in literature is from a very recent article on MGRS. It highlights the lack of data on prognostic markers. It highlights the lack of clear, definite response criteria and clear outcomes or treatment guidelines. So I think this is a very good opportunity for a high quality prospective data to be generated. And in summary, I think the key to treating MGRS is crosstalk between the nephrologist and the hematologist and the pathologist also. If that becomes into this, it'll be like a Noah's Ark, but we don't recognize each other's language sometimes, and I think the communication would be the key to management of these disorders. Thank you.
The first question, ma'am, is there a role for PET-CT in diagnosis of MGRS if bone marrow is normal?
So PET-CT, low-grade, these conditions are associated with low-grade lymphomas, and they are very often not PET-avid. So PET-CT can pick up something, the likelihood is low, but officially in the diagnosis of lymphoma, a PET-CT is one of the options, yes. Okay, if you want to be very thorough, but the yield will be very poor.
Okay, ma'am, depending on the pretest probability maybe.
Or, sorry?
Depending on the pretest probability maybe, means if we are thinking.
I would say so, yeah. It's part of a complete evaluation, yes.
Thank you, ma'am. Ma'am, the next question I think you have answered is, are you following a different treatment regimen for MGRS and multiple myeloma?
No, so we follow the same treatment regimen for multiple myeloma and MGRS.
The next question, what is the outcome of treatment of MGRS cases that you have so far encountered in terms of renal and hematological parameters?
So there's a very discordant responses. We see a good response as far as the hematological parameters go, but very often the proteinuria doesn't reduce. Sometimes it increases. So it's not consistent, I think, yeah. And I think patients who have taken for transplant have had a much more difficult course than other autologous transplants.
Thank you, ma'am. One more question. Is light chain restriction with 10% plasma cell and non-biopsiable kidneys enough to warrant a diagnosis and treatment for MGRS?
More than 20% plasma cells?
Light chain restriction with 10% plasma cells on biopsy and non-biopsiable kidneys.
So we have conditions like this where we don't, especially it's not just in the renal biopsies, even in neuro it's very difficult to get a biopsy in any patient. So generally if there is no other cause for the renal dysfunction and this is there, we treat, yes, yeah. For whatever benefit the patient may get.
Thank you, ma'am. One more question. If we cannot identify the clone, then what would be the treatment that we give, ma'am?
Yeah. So this is a really difficult thing, because sometimes they say the clone is how do we detect the clone? The plasma cells may be only a few. The clone is detected through the abnormal FLC ratio or the presence of the M band. So if that is very rapidly being deposited in the kidney, or if the clone is very small, we won't pick it up. So the answer is, what do you do? I think the recommendation is based on the biopsy itself. If there is a clear spectrum of MGRS, we should consider if your medication is not working, I don't know, ARBs or whatever else it is, then we would treat, yeah. Based on that is actually, you know, that like a gene map I showed, the histopath diagnosis gives you the diagnosis, you know, more or less.
Thank you, ma'am.
Yeah.
I'm sorry, but one more question.
Oh, okay.
Are we using daratumumab in our center, and what is the latest choice of chemotherapy for these
Yeah.
patients?
So daratumumab is a anti-CD38 antibody, monoclonal antibody, which is used in multiple myeloma and has been shown to be superior to conventional chemotherapy. It's expensive, which restricts our use, but we do give it to patients who can afford, yes. So the difference between your response rates would be around in the range of 10%. Yeah.
Thank you, ma'am.
Yeah.
Ma'am, I request you to kindly accept a small gift from on behalf of the organizing committee for RCC.